I like what he said about the PCNs, and you know that Kenya modeled a lot on what Cuba has.
Yeah.
And, having visited Cuba and seen how their primary care models work, what I think I took home is that it's not the technology or the rocket science in it. It's actually thriving in the simplicity of it.
Yeah.
And I'll talk about Kisumu, for instance. The investment in their ambulance service is not a lot. The whole county actually just has about 7 ambulances. But it is the AI and the technology around it that has made those 7 so highly efficient that it probably has one of the best responses I have seen in this country. And I've tested it, so I'm actually speaking from experience that I called for an ambulance using their app, and I had one in 7 minutes.
7 minutes?
7 minutes.
That is impressive.
7 minutes.
Wow.
And what did it take? Just a properly done call center with technology, and the fact that when you call for an ambulance, the moment you made that call, even if you didn't complete it, it has already located you. So the nearest ambulance is already dispatched to you. So even if your phone drops, they will find you. And I'm like, what is so hard about scaling this nationally? So can you imagine having a PCN with an ambulance sitting there, even if it's just one, but with the capacity to be able to reach out in that manner? We will actually be able to do a lot in terms of emergency response. The second thing is that the ambulances don't sit in hospitals. Again, a waste of resources. Because if you go to most of our facilities, ambulances are sitting there waiting to be told, take a patient here, take a patient there. And when they're not taking patients, they're ferrying charcoal and potatoes for the hospital. And it's just one of those pieces, and you're thinking, why then do we have 5 sitting here? When these 5 could actually be potentially out there. Taking care of the mother who has collapsed on the roadside, for the one who fell off the motorbike in Makongeni, those kinds of things. So I think looking at where we're going and looking at and that's one thing I love about counties, because everyone decided this is our challenge and decided to find a solution for it. So we don't have to keep repeating this all the time. We can simply say lessons learned, best practice here can apply nationally. Can we be able to put this around and be able to see how it sorts our mothers? Yeah.
And this conversation has been really riveting because we've gone through transportation, we've gone through road networks, we've gone through, I'm really sorry your aunt passed away. I really wish there was a healthcare provider there.
The beauty about it?
Sorry?
The beauty about it?
Yeah.
Is that we picked the girl,
yeah,
and now she's a mother.
Oh, that's amazing.
Yes, so it wipes our tears dry to some good extent.
Yeah, that at least there was a happy ending.
Yes.
Yeah,
She became a mother about 2 years ago.
Oh.
Yeah.
A boy or girl?
The baby?
The baby, yeah.
Baby's a girl.
A girl.
Named after the grandmother.
Oh, that's so sweet.
Yeah.
But I really like the conversations that we've been having about, especially the Kimomor project, One Health, because I also know at some point, maybe before you can even get to the expectant mothers, you might have to vaccinate cattle because of cultural, So there's so much going into figuring out a framework that works for different people, different cultures.
Absolutely.
And I loved that about Kisumu, 7 minutes to get an ambulance. That's fantastic. That is absolutely fantastic.
Yeah.
And like what you said, Dr. Chris, if you can actually take models like that work and then build them, it would really change the healthcare landscape of Kenya. So thank you guys so much for that. And my last question to both of you is, what is your closing vision for maternal mortalities in Kenya? What would you like to change in this space? Through partnerships, through governance, what would you like to change?
Ladies first.
I would always say everything begins and ends with governance.
That's true.
It doesn't matter what you're talking about. It doesn't matter how many resources you have at your disposal. If there is no good governance to ensure they're put to best possible use, you will still not have the outcomes you desire. It begins and ends there. And we look at it from various service points, but I would probably want to just take an angle of from the community. What have we put in place? One, to empower the community to understand their rights, But every right you have as a human being comes with a responsibility. So we also must have that from the responsibility side. It is not enough that the government will put all these services in place for you. Have we empowered you to know why they're there? The importance of you coming, not only coming, but in a timely manner. Because if we can't do that, we can't be able to then start with the first aspect, which is demand creation. When the demand is there, we are all driven to satisfy the demand. So we're sitting in a place where our demand has been in numbers. We have been able to get moms to come for antenatal clinic, and we're very proud that we have 94% coverage in antenatal clinic attendance. And that is slowly creating demand, which then moves us to the next level, and that goes to service provider level. Service provider, two-part. One, the institution. Is it ready? Are the structures in place for whatever level it is, created to ensure that when this mother finally lands with us, the quality of care that should be expected is actually given? That there are mechanisms in place for us to ensure they can be correctly referred where need be. That we have properly and adequately financed this service so that we are doing away with shortcuts. Because it doesn't matter if it's not enough, and if it is given and it's not properly accounted for, then we are really not going to make headway. And the very basic unit where health financing goes to is all the way down to the care provider at the facility level or at the community level. The second part of the service provider is now looking at the actual professionals. Do we have the right professionals for the job? Are we actually ensuring they are properly trained, that the numbers are adequate? And we have systems, laws, and policies that guide this, all the way from what our training schools look like. So we really have a lot of work to strengthen the output that's coming up. We have had this over and over, that the quality of healthcare providers we are now graduating is going down. That's a governance issue. It means we're failing somewhere, and we must bring that quality back for us to expect that when they are finally in the workplace, they're delivering. We must have in place mechanisms that ensure that we're actually retaining the services, because it pains me when I see us graduating all these nurses so that we can send them abroad. And we're not sending them abroad because we have an excess. We're sending them abroad because we are unable to absorb them. So what needs to change around our models for human resource for health management to make it sustainable? Because we are still far from reaching our targets. We have CHPs who will do an amazing job, but then they're referring to who? To that one health center that has one nurse on call at night, alone and unsupported? I mean, it beats the purpose.
That's true.
When we move along away from the health facilities, we have to come to our ministries of health. And we both have to look at the county level and at the national level. So we have had the challenge where our national level has been responsible for policy making, but in terms of taking up of these policies and implementing them, which is majorly a county level issue, we're not seeing that translation. And partly because policy implementation comes at a cost. And so anytime at national level when we are coming up with new policies, and they must be immediately followed by the strategic plans that tell us how are we financing the implementation of these policies, so that the actual people on the ground implementing, which we know is counties because they are carrying the bulk of service provision in healthcare, then know that they are capacitated to be able to put this through. So all that is purely where we say good governance can never be subtracted from the implementation of all this work for it to make sense. And lastly, looking at our development partners and knowing that, yes, we have their support and we really appreciate their support, but are we able to ensure that we are able to put their support to the best possible use? And what Chris was saying, data must guide. Data must tell us where the dollar is best used to be able to have the highest impact on prevention of maternal mortality. So we have to, and this is why we said you cannot disintegrate this anymore. All these people have got to come to the table together. You may be the one bringing the money, you may be the one doing the work, so we have to be in concert. Remember, I am a dancer. If you and your partner are not in sync, you're going to trip and fall over each other's feet. We have been tripping and falling long enough. Yeah. Let's get to practice. Let's get this synchrony going. And that synchrony can only be determined by good governance at all these levels to ensure that we have the best possible output.
That's very true. And when we're talking about synergy and we're talking about having a holistic framework for the Ministry of Health, for our partners, and also for the community, and also making sure that the framework also incorporates national and county levels of governance. So at the end of the day, maternal mortalities are reduced. We actually hit SDG 3 and reduce maternal mortality by 2030. And everything that you've talked about really does go a long way, because we also need to capacity build our health workers to make sure that we are giving them the best quality of care, and also that the health facilities are actually there. They're well stocked. Commodities exist, and the communities are empowered so that they actually know what their rights are, which, by the way, the government has done a really good job with that, empowering mothers, young people, through a lot of digital platforms like apps that we have worked with Amref as well to create. And as we close, Dr. Barasa, what is your closing vision for reducing maternal mortality in Kenya?
To me, I'll approach it from two perspectives. One, we just need to have a commitment. Commitment towards that. And I will look at it from a personal commitment. If you've been affected the way I have, and I know a good number of us have been affected, because trust me, Halima, when a mother dies, a lot of things change. A lot of things change, and it becomes very, very difficult for the children to walk through that. Because just looking back over the 20 years, and I can basically walk through, and I can tell what were the fundamental things that changed when my aunt died, for that matter. So that makes me very committed. I would not wish to see any other child suffer because their mother has died, for that matter. So a scenario where it becomes everyone's responsibility, okay? So that we are talking about, these things everywhere you go, because whether we are at home, whether in the communities, whether at work, or wherever we are, just making it a discussion, okay, so that it becomes everyone's concern. And in that way, we will be able to have a movement that can be able to lead it to a particular direction. And the direction that we wish to see is to actually no mother should ever die giving birth, or in the process of giving. It's a natural process that should actually be able to be self-propagating, for that matter. So we should actually facilitate. So a movement where all of us are concerned, and that we are putting our resources together to ensure that doesn't happen. The second commitment is what I'm glad as Amref we are doing, because we have made it our responsibility. And we are calling it a big bet such that we don't want to approach this maternal mortality from bits and pieces, because that, as Nelly has said, this has happened for many years. People have been doing bits and pieces in small ways, have a small project implementing this and this. That is good. But then the thought we have is we need to make this bigger, and have a multi-stakeholder engagement. Bring whoever is responsible, or whoever has an interest in this, whoever has resources, whoever has the technical know-how to have this. And I will summarize that in we usually call it the 3 P's. One is to just harness the people. So people starting from the community all the way to institutions that are big enough to manage this. Then 2 is the products. She mentioned the issue of a commodity, we call it carbetocin, a drug that we believe, if it's put within our systems, is going to help at length in as far as managing this. Then the third P is looking at the platforms of engagements, and we have a window of opportunity in this country, Halima. If we miss it, then we shall never be here again. And the window of opportunity is the political platform that is very much pro primary health care, and we believe that is actually going to provide a paradigm shift. So the political platform, the policy platform that is very, very pro again primary health care initiatives. And definitely we have a problem that we need to solve, as it were. So we have a narrow window of opportunity that we need to work together as a country, recognize that, and be able to really work towards achieving this. So which platforms are we going to stand on to be able to enhance the discussion around maternal mortalities? And I want to believe that if all of us remain committed to this cause, then through proper governance systems, through strategic partnerships that we have, through appropriate policies, and then lastly, just being accountable for your actions, then you should be able to have an end to maternal mortalities. The SDGs talk about those are the sustainable development goals, talk about the 3.1, 3.2. They have given us a target that by 2030 we should have reached this particular target for this particular country. I say that I usually crack numbers, but I don't want to confuse people with numbers. My wish will be that we target towards having 0 mother dying while giving birth. Because when I talk about those targets by the UN and globally, we may have a misconception that we can allow a few mothers to die. The point is that we should have 0 women dying, 0 children dying, and that is my target. So I'm setting my own targets. and all of us actually setting our own targets. Yeah. Nelly, myself, as Amref, we are asking ourselves, why should we allow a few mothers to die? Yeah. So we should basically work towards 0 maternal deaths in this country. And it's possible, it's doable, if all of us can work together in a concerted way. Thank you.
And at the end of the day, we all have mothers. We are all children. And we need to make sure that no family goes without a mother. You know, no one has to go through that pain and that loss. And the only way that is going to be possible is through working together with the political platform of primary care networks, making sure that everything is in place so that we can make the sustainable development goal a reality. And thank you so much for joining us, both Dr. Chris Barasa and Dr. Nelly. Your insights have been amazing. I have learned so much from both of you. Thank you. Dr. Chris came out more projects like that is impressive, and I know it's in Turkana. And I know you guys also use data to track the communities moving. I read about it. It's an amazing project, and it will go a long way. And Dr. Nelly, I learned a lot about the Ministry of Health and Devolution because, you know, Dr. Barasa, you're right. I was 1 year old in 1993.
No, we know.
But I learned a lot about devolution. I learned a lot about how, you know, the subsequent governments have been working together to make primary care networks and primary care bring it to the forefront of, you know, some of the problems that we are having in Kenya. Absolutely. So, you know, and capacity building, you know, we need to capacity build our healthcare professionals so that not only do they take pride in the work that they do, but they also give hope to the community that, you know, babies and mothers are well taken care of. Absolutely. So thank you so much for your insights.
Thank you.
Thank you for hosting us.
Thanks for your time.
Oh, thank you.
Thank you for allowing us to visit.
As we wrap up today's informative episode on governance and strategic partnerships, towards achieving an end to maternal mortalities in Kenya, our heartfelt appreciation goes to Dr. Chris Barasa and Dr. Nelly Bosire for their contributions and expertise. Our discussions have spotlighted the necessity of robust governance and strategic partnerships in the fight against maternal mortalities across Kenya. Their insights have emphasized the need for synergy between policy implementation and community engagement to steer us towards a future where maternal health is not just a goal but a reality for all Kenyan families. If you have any questions, concerns, or queries, please connect with us at Amref Health Africa. So our Twitter is at Amref_Kenya, our Facebook is at AmrefKE, and our Instagram is #AmrefKenya. Thank you so much. I've been your host, Halima Sabwa, and goodbye for now.
Thank you.